Oh, look at this thing. No. Oh, it's so bad. No, no, no. Is yours? I was not with it. Yeah. Oh, that was one of the things. Okay. Yeah, that's yours. Okay. It was never plugged in. I was like, the amount of times that I plugged in and it's like thinking it'll charge and nothing happened, but I'm like, Yeah, that one looks like a freaking car ran. Oh, yeah, it was. Where the plug it in, and then when it then it was full. That like you can't get the covers open sometimes on the floor. Yeah. And I'm just like, well, I guess I'm not using it here.
Oh, gone out. I've been sitting on my desk. Darn it. Okay, it's time to start. We have 3 lectures left and I have 4 topics to cover. That means one of those topics is going to get podcasted. So we have to cover blood-based infections, which we'll do today. We have to cover GI infections, respiratory infections, and urogenital / sexually transmitted infections. That's 4 topics. We have 3 sessions left. So the GI infections are going to podcast. That's important because some of you will do family medicine. Pediatric diarrheal infections are going to be important for that type of career. So all the GI stuff I'll do on a podcast. I'll do it probably sometime this week. That means Friday, we'll do respiratory infections. Monday, then we'll do UTIs and sexually transmitted infections, which is a tall order, but hey, makes life interesting, right? So today we're going to do bloodborne infections. The slides are very long, and I've decided essentially the thing to do is to try to fish out what's going to be important for you all. What sort of things are you guys going to see most often? Plague, for example, is a very important bloodborne infection. Are you guys ever going to see a case of plague in your careers? Unless you work in an urban, rural environment where there are outbreaks of simian plague, you'll never see a case of plague. Unless it's used as the biological agent in warfare, you're not going to see it. So I'm not going to talk about plague. There are other very interesting things to talk about you're probably never going to see. You can never see a case of Chagas disease. Unless it's an immigrant, probably not. So I'm not going to talk about Leishmania infections, things like that. What are you going to see? You're probably going to see infective endocarditis. Really good case you'll see that. So we'll talk about things like that. Okay, review of the heart and all that. You've been there, done that, got the hat. Malaria, you ever going to see malaria? If you do overseas work, yes. If you see immigrants, yes. You're going to see a case of malaria in the US? No. All right, so malaria is interesting, but we're going to skip malaria. HIV, you're going to see HIV. So let's talk about HIV. So HIV is caused by a human retrovirus. A human retrovirus. It's retro because it's an RNA genome virus. It has a reverse transcriptase enzyme that makes a DNA copy of that RNA. So you have a single-stranded RNA virus. The reverse transcriptase makes a double-stranded DNA copy of it. That double-stranded DNA copy is then inserted, integrated into the genome of the host cell. You get this virus from bodily secretions. You get it from things like semen and other types of solutions like that. Blood, semen, it's not in sweat, it's not in saliva, so you can't pass this virus casually. You get it through blood products that have not been properly tested or screened, or through sexual contact. The most effective way of passing a virus is through male-to-male sexual contact. That's the most efficient way to pass it. Can it be passed by male-to-female sexual contact? Yes, but not as effectively. The virus has a particular structure, and this is important because there are some proteins that are important for diagnosis. So you have these surface glycoproteins. The surface glycoproteins are the so-called GP120, bless you, and then there's the GP41. GP120 is the main one. These are embedded in a membrane. So this is an enveloped virus. Underneath the membrane, you have a matrix that is a capsid. The capsid houses the RNA with some associated proteins. The integrase and the polymerase molecules. One of the capsid proteins is a protein called P24. P24. P24 is going to be hugely important for serology. So that's a protein you have to remember. P24. There's another matrix protein. The matrix protein is being right underneath the membrane. That's called P17. So P17, P24. The other protein you need to know is the reverse transcriptase molecule, which is a product of the POL gene. The POL gene also makes the integrase protein that integrates the DNA copy of the RNA into the host genome. These are important because they're targets for anti-HIV drugs. And then the envelope protein as well, that's important because that's how the virus gets into host cells. The target for the surface glycoprotein is the CD4 protein on the surface of T helper cells. So the main cell the virus will attack are T helper cells. You might remember from our immunological forays, the T helper cell is one of the hinges, one of the pivots upon which the immune system turns. By hamstringing that cell, you will hamstring the entire adaptive immune response. So by killing T helper cells, you will completely do away with adaptive immunity. Therein lies the danger of HIV infections. Now, T4 has a co-receptor called CCR5. CCR5. CCR5 can be replaced by another molecule, and it gets replaced by another molecule in later infections. We'll see why here in just a bit. Some people have mutations in the CCR5 gene. Those people with mutations in the CCR5 gene are resistant to HIV. Those people are few and far between, but they do exist. All right, so when HIV enters the bloodstream, it will target CD4 positive cells. Those are T helper cells. Macrophages also have CCR5, so macrophages can also be infected to some extent. Some macrophages have CD4 as well, so some macrophages can be infected. HIV attaches to CD4 via the GP120 envelope glycoprotein. With help from CCR5, the virus infects the T cell. The virus uncoats inside the T cell. The RNA is reverse transcribed into DNA. The DNA complexes with the reverse transcriptase and integrase. That gets it into the nucleus. And then it gets incorporated into the DNA of the host cell. The virus will then be transcribed by the host cell. It will make HIV RNAs and proteins. The T cells will now start to produce HIV particles, infective HIV particles. Keep in mind that the reverse transcriptase that makes the viral copies of the genome is extremely error prone. So every time the virus gets copied, there will be mistakes in it. Now you might say, well, darn, you're making mistakes. Some of those viral particles will be non-infectious. They won't work because you'll have so many errors in the genome, and you'd be right. A fraction of the HIV particles will be non-infectious, but most of them will be infectious, and they'll be different. Because of this, all attempts to make an HIV vaccine have failed, and have failed spectacularly, because the virus is constantly changing inside your body. That's going to be important when we talk about treatment. So if left untreated, the infection will pass through 4 stages. These are characterized by the 4 Fs. The first stage is flu-like symptoms. Flu-like symptoms. That's your acute stage, which starts as soon as the individual gets infected. The replication of HIV will usually peak until about week 6 or so from the flu-like infection. The second stage is falling count of CD4 T cells. Falling count of CD4 T cells. The CD4 T cell counts will usually fall below about 500 cells per milliliter. When they fall below 500 cells per milliliter, now the patient will start to experience certain types of infections that you don't see in healthy people. If the T cell counts stay above 500, usually the patient feels fine. They fall below 500, now these other infections will start to come online. So the flu-like symptoms, then stage 2, that latent phase where the patient feels fine. Then we have falling counts where we get below 500 T cells, CD4 cells per milliliter. Then stage 4 is the final crisis, where the T cell counts now start to get below 200 cells per milliliter. That's you. There. Zoom doesn't like it if you don't get out of. So flu-like symptoms that will last anywhere from 2 to 6 weeks after infection. Then the patient will usually feel fine. That's the latent phase. Latent phase can last years, months, weeks. The T cells or the macrophages will take the virus to the lymph nodes. And the virus usually has lots of T cells there to infect. So your viral levels usually will start to rise. The immune system in usually young, healthy people will start to get the edge over the virus, and the virus levels will start to drop, and the T cell levels will usually start to come up. So that's your feel fine. And again, that magic number is 500 CD4 cells. So if you're above 500, then stage 3, that's your falling. In this case now, you're below 500. So you're below 500, that's falling. And then stage 4, now you're in full crisis. And that means you are below 200 CD4 positive cells per mil. And now you're going to start to see all kinds of oddball opportunistic infections you do not see in a healthy person.
Thank you.
So one of the really important things will be measuring CD4 cells in a patient's blood. That will be absolutely key. Very good. So what sort of things do you usually see? Usually during the latent phase, you'll see things like, oh, that's where that went. You'll see reactivation of things like if they had chicken pox, their varicella zoster infection gets reactivated. If you reactivate that, what do you get? Shingles. You get a young person who comes in with shingles once. Okay, it's not common, but it happens. They start coming in with shingles repeatedly. You put in an order, draw some blood, get their CD4 cells checked. And if their CD4 cells are down, then you'd start looking at HIV serology and viral counts and things like that. That person probably has AIDS. Another thing these people are very susceptible to is tuberculosis. We'll talk more about tuberculosis when we talk about respiratory infections, but with tuberculosis, it can become disseminated. And disseminated tuberculosis can go anywhere. They can also get infected with types of tuberculosis that you don't see in healthy people. So Mycobacterium tuberculosis normally causes tuberculosis in humans. In AIDS patients, you can have Mycobacterium avium, Mycobacterium intracellulare, the so-called MACE complex, which cause an atypical type of tuberculosis. So tuberculosis, regular tuberculosis, or atypical tuberculosis. As the T cell numbers really start to drop, the other thing you start to see is oral thrush. Any farm people here? Anybody grew up with either horses or thrush on the hoofs? Do you see? No. Thrush. If you deal with farm animals, horses will get thrush on their hoofs. There's a grayish film, grayish, yellowish, golden colored film that you get usually on tissue, and that's caused by the yeast Candida albicans. Oral thrush is characterized by kind of a yellowish grayish film on the gums and tongue. If you scrape it off, you can culture it. You'll get a budding yeast that can actually grow as pseudohyphae. You'll see it on the gums and on the tongue, and the patient usually will have incredibly bad breath, usually with thrush as well. And this as the CD4 count starts to drop below 500, you'll start to see oral thrush. As Epstein-Barr virus gets reactivated, you get this non-scrapable whitish film on the tongue. That's called oral leukoplakia. And that is caused by Epstein-Barr virus. Now, virtually everyone in here has Epstein-Barr virus, but your Epstein-Barr virus is kept at bay by your immune system. Without a functioning immune system, Epstein-Barr virus starts to divide, and it causes B cells now to grow uncontrollably, and it can also transform epithelial cells, like the ones on the tongue. So oral leukoplakia, sometimes called oral perileukoplakia. And again, that's due to this non-scrapable white plaques on the tongue. As the T cell levels further fall, human herpes virus 8, which again, virtually all of us have been infected with and doesn't cause any symptoms, in people with low CD4 counts, will now start to cause epithelial cells, particularly those of the skin, to grow uncontrollably, and they will cause Kaposi's sarcoma. These can appear on the skin most commonly, but they can also appear in the throat, GI tract. If they appear in the GI tract, they can bleed. I don't know why this will not get in focus today. That looks really fuzzy to me. That looks fuzzy to you? No, it's not the light. You'll also see them on the genital area. These are red open sores and they bleed. You think that's a problem?
Well, it's just.
Oh, it's in your eye button. That's not good either. That's a little bit better, maybe. Better? Yes. Okay. So Kaposi sarcoma is, again, you virtually never see that in somebody who's healthy. But in somebody with active HIV, you will see it.
Your capsule.
So any one of these infections is usually an indication that somebody's CD4 levels need to be checked. Once you get below 200 CD4 cells per milliliter, now you get so-called AIDS-defining infection. So fungal pneumonias, become very common in AIDS patients. So histoplasma, capsulatum causes a severe fungal pneumonia. We talked about Cryptococcus. This will cause pneumonia that then can become a severe meningitis. Probably the most common infection you see in HIV patients is with the fungus Pneumocystis. Eurovecii. This thing, when you see it in a sputum swab, does not look like a fungus, but genetically it is a fungus. And Pneumocystis pneumonia, PCP pneumonia, Pneumocystis pneumonia, PCP, can be deadly in an AIDS patient. There's several others that are just not as common, but you still might see them. Oh, another biggie. And this will be a biggie if you work with transplant patients. In transplant patients, one of the biggest threats is this virus, cytomegalovirus. Cytomegalovirus is the bane of transplant wards. It causes a really severe pneumonia, so-called giant cell pneumonia, in transplant patients that can kill them. The virus, because it causes a general viremia, can also spread to other organs and greatly compromise the function of those organs. Cytomegalovirus can also infect HIV patients. Patients with acquired immune deficiency syndrome. That's another concern essentially of your HIV patients is cytomegalovirus. You get these large linear ulcers surrounded by normal appearing mucosa. That's a sign of cytomegalovirus infection. Cytomegalovirus can also cause retinitis, inflammation of the retina. It can also cause inflammation of the colon, brain, and the lungs, in that order. And any biopsy, you'll see these big kind of owl's eye inclusions in the nuclei. And blah, 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 blah. There's lots of other things they get. So those are the biggies. There's plenty of others we could talk about, but those are definitely the biggies. Let's talk about diagnosis of HIV. There's an HIV-1 and an HIV-2. They have the same structure. HIV-2 is not as common. It's more common to Africa than it is to North America. It's also not as infectious. So the disease you get with HIV-2 is not as severe. But the antibody antigen tests that you run for HIV will detect both 1 and 2. So there's the antibody antigen tests. These look for the P24 capsid protein. And they look for antibodies against it. That's an A, by the way, A against it. This immunoassay has very high sensitivity and specificity. If you get a negative result on this test, the patient really doesn't need to be tested any further. If you do get a positive immunoassay, that means infection is likely, but it will need to be confirmed with another test. Old books or old papers will say you should run a Western blot. Western blots are not reliable and therefore they're not recommended anymore. So if you see in old protocols, send it to the lab for a Western blot. No, those are old protocols. CDC recommends against Western blots. They're long, they're tedious, they're expensive, and they're not reliable. All good reasons not to recommend a Western blot. All right, the next test, you can either do a antibody differentiation test that tells you if you have, I'll do this in a different color since we're doing different tests. So that's your kind of first line here. You can do an HIV-1 or 2 antibody differentiation test. That tells you if you have HIV-1 or 2. And if that test is negative, you can do an HIV nucleic acid test, which is abbreviated NAT. Don't confuse that with the insect that buzzes around your ears and eyes. This directly looks for the viral RNA. So if this test is positive, the person is definitely infected with HIV. And if it's negative, that means the first test was a false positive. You do these tests, everything's positive. Next thing you check, what do you think? CD4 cells. And this is going to be important throughout the infection of the patient. Once you do that, there's another test that the patient will need to have, and that's a viral load test. Viral load. That tells you how much virus is in the blood. Typically, increased viral load is associated with poor prognosis. Low viral loads are associated with good prognosis. So these are tests that the patient will have to have throughout their life. One more thing about HIV before we talk about treatment. Remember that this virus can be passed vertically. That means it can go from mother to baby. It can go from mother to baby through the placenta. Excuse me. It goes from mother to baby from the blood that the baby is exposed to during birth. Doesn't pass the placenta, just mother's blood. And it can also be released in breast milk. We talked about anti-HIV drugs to some extent already. I'll just give you a brief review. You will always treat using combinations. You use combinations of drugs. So your cocktail has to be tailored to the virus and its genotype, but typically you're going to include at least 2 drugs. Usually that will inhibit the reverse transcriptase. And then usually nowadays, one other drug that inhibits the integrase. Now there are 2 drug cocktails now that just have one of these and one of these. But usually there are at least 3 drugs you're going to include. There are also protease inhibitors. These have a lot of side effects, so they're not used so much anymore, largely because the integrase inhibitors are much better tolerated. So those are used a lot more often than are the protease inhibitors. I swear this table is on an incline. Pregnant individuals who are newly diagnosed with HIV should start treatment right away. there are particular cocktails that have been shown through quite a few pretty rigorous clinical trials to be safe for both mother and baby. So for example, there is zidovudine and lamivudine. And these are quite safe for mother and baby. And if you combine it with another drug that inhibits reverse transcriptase, this drug called efavirenz, this is probably the widest, most widest used cocktail in pregnant women. Not only can it prevent the mother's load from going up, it can prevent the baby from getting infected. And then zidovudine during breastfeeding can suppress the virus such that it's not released into breast milk. So an HIV positive mother can give birth to a baby, breastfeed her baby, not pass it to her baby successfully. Any questions about HIV? Let me read you a case study. This is a real case study. Patient X, let's call patient X David. David is a 42-year-old man. He presents with fever, cough, and dyspnea. What's dyspnea? Right. Can't breathe, trouble breathing. David is HIV positive. His T cell count is 180 CD4 positive cells per milliliter. 180. Is that high, low, normal? Quite low, quite low. Okay, fever, cough, trouble breathing, sounds like pneumonia. So it sounds like an HIV-defined pneumonia. So probably the first thing you should do is a sounds like X ends in ray. Thank you, chest X-ray. You could have any number of AIDS-defining pneumonias. Odds are he's got pneumocystis pneumonia. That's the most common AIDS-defining infection. Patient Y. Let's call patient Y Charles. Charles has white plaques on both sides of his tongue. And the fact that they are not scrapable. Oh, sorry. Charles is a 32-year-old man. He's referred to your clinic by his dentist, who detected white plaques on both sides of his tongue. You try to scrape the plaques with a tongue depressor, but you realize they can't be removed. Upon questioning, Charles tells you he's been losing a lot of weight lately, even though he hasn't been exercising or watching his diet at all. You decide to ask for an HIV antibody antigen immunoassay, and it comes back positive. What's wrong with Charles? He has HIV, and what's the stuff on his tongue? Oral hairy leukoplakia. So that's an HIV activation. So his CD4s, which you're going to need to check, are probably below 500, but not below 200. So you want to start treating him to get him back above 500 so he gets in that feels fine stage. Rather than, because the 4 stages, flu-like, feels fine, falling, CD4 levels, and then final crisis, where it becomes, when you get below 200, now you're in full-blown AIDS. A acquired immunodeficiency syndrome. Let me just say one more thing about treating ACE patients. For some of you, this will be obvious. For some of you, you probably need to hear this. Some of these people are gonna have HIVs because they practice a lifestyle that you're gonna find pretty abhorrent. Do you treat them any differently? No. Everyone who comes to your clinic gets the same care. When you guys graduate, you will stand, you will raise your right hand, and you will take the nurse's pledge. That nurse's pledge involves you will render care to someone regardless of not of what you think of their lifestyle. You may find their lifestyle abhorrent. You're perfectly entitled to think that. I definitely think that. But the care you render them, the compassion you render them, has to be the same. As part of being a Christ-like minister of his mercy, as part of being a nurse. Amen. And that is the kind of care you're going to have patients you're not going to like. You're going to have people you're going to want to throw out the window. You may even have me someday. You'll probably want to throw me out the window. Okay, but you got to give me the same care that you would give Morgan. Okay, Morgan's not going to chew your head off. I just might. Okay, so Morgan, you want to do everything. You want to give your life for her. Me, you're going to want to throw me out the window. Don't. All right, let's go ahead and take 5. We'll come back, talk about endocarditis.
If we haven't turned in a second, like, if we didn't go to the natural science seminar, are we still able?
Yeah,
to
just turn it in.
Thank you.
Hey, Devin, your foot feeling any better?
Yeah, it is like sort of okay.
Okay, is it
It's just
swollen?
really sore and sharp pain right now.
Oh, so if you touch it, it hurts?
Yeah,
So you can't put any weight on it at all?
not really right now. No.
Okay. Well, I told you not to
Hopefully
drop
it
a
gets
bowling ball
better.
on your foot. Your colleagues are back there snickering. All right, so you're probably going to be on crutches next time we see you, right?
I'm hoping not. I
You're
hope I
hoping
just
not?
slept on it. I hope I just slept on it wrong and that's why it hurts.
Okay. So you're hopeful that it's just a sprain?
Yeah, I mean, it's an old injury. It's just like sometimes it gets bad and then sometimes it's like, I don't know, it's just all over the place right now.
Okay. Well, hang in there. I'm glad you joined us via Zoom. So can you hear me all right?
Yeah.
All right. Or Devin messed up her foot. So she's in a heap of pain. And so she's zooming. And hey, how about those Lady Cougars? Championship. Hubba hubba.
They're playing.
Mm-hmm.
Yeah, they do. Is it 14 hours? That's what our Josiah qualified for nationals on Saturday. And it's in March, so the rest of us are getting back. Because we can't get some.
That's indoor nationals.
Yeah.
We qualified this early. Wow.
First meeting of the season and we qualified. He had a B standard, so
He didn't sound very confident Friday. I said, how do you feel?
I don't think anybody was confident.
He was like,
Pre-meet didn't go, the pre-meet was there, and then his third throw of just his regular flight before finals, it was like a 16.45. Qualified for nationals with a B standard. And then he made finals. That was his best throw though. We were all pretty excited.
Yeah, he didn't think he'd do very well. He was not Very
I don't
confident.
think he was expecting it on the first meet. Like, that was his goal this year, was to qualify for nationals, and like, we've seen it in practice, and he's been close in practice, but he's never thrown that far in
He had
practice.
a really good day.
And, yeah, we're all just like, oh, that's gotta be it, that's gotta be it. And they
Yeah.
read it, and,
Oh. Had a really good day. And we have a skeleton crew today. All right. Time to get back in the saddle. Endocarditis. So the heart wall is made up of 3 layers. There's the outermost epicardial layer, then the myocardial layer, the middle layer, the big gun, if you will, of the heart. And then the endocardial layer, the innermost layer, and that is the layer that's going to get inflamed if it gets damaged. The part of the heart that is most susceptible to endocarditis are the heart valves. This is called the mural, M-U-R-A-L, endocardium. People with prosthetic heart valves are especially susceptible to endocarditis because of the formation of biofilms on those prosthetic heart valves. Now, if you have inflammation of the endocarditis, of the endocardium, that's called endocarditis. And if it is caused by microorganisms, it's called infective endocarditis. So non-infective endocarditis very often is the first stage to endocardial damage. In this case, you have some sort of damage due to trauma. That trauma could be any number of things. You have platelets adhering to the damaged endocardium. The damage exposes collagen. Platelets adhere. They will form tiny blood clots. This is called non-bacterial thrombotic endocarditis, or NBTE, non-bacterial thrombotic endocarditis. The tiny clots and fibrin can develop into what's called a vegetation. Vegetation. And if you have vegetations that form on the heart valves, that tends to damage them, and it makes them harder to open and close because that damage will cause healing. Healing causes fibrosis. The fibrosis after the scars contract will cause the valves to shrink. When they shrink, they don't close all the way. They become incompetent. The exact cause of non-bacterial thrombotic endocarditis is not completely understood. Malignancies can cause it. So pancreatic adenocarcinoma can cause non-bacterial thrombotic endocarditis. Another situation where you can get non-bacterial thrombotic endocarditis is with systemic lupus erythematosus. In those cases, you get antibody-antigen complexes that settle in the endocardium. And they cause inflammation. And this type of endocarditis is called a Liebman-Sachs endocarditis. Liebman-Sachs endocarditis. This type of endocarditis, therefore, is going to be a type 3 immediate type hypersensitivity. Because type 3 immediate type hypersensitivities have to do with antibody antigen complexes that get lodged in tissues and cause damage. A Liebman-Sachs, and Liebman only has one N, sorry, endocarditis. Liebman-Sachs endocarditis is associated with relatively large vegetations that look like warts. And for that reason, they're sometimes called verrucous vegetations, because they look like warts. And a medical term for a wart is a verruca. So for infective endocarditis, bacteria have to enter the bloodstream. Usually, if bacteria enter the bloodstream, they get cleared by the immune system relatively rapidly, but sometimes you can have large quantities of microbes that get into the bloodstream. So if a person has an obvious open wound or an abscess, abscesses are a really common way to cause endocarditis. Surgical procedures can do this, as can dental procedures. And if these microbes float around long enough, they can reach the heart and they can adhere to the heart valves, in particular if the heart valves have previous damage. One of the biggest causes of previous damage is rheumatic heart. So rheumatic heart there should be a U there, sorry. Rheumatic heart is caused by group A strep. So that's strep pyogenes. In its cell wall, strep pyogenes has a protein called protein M. Protein M is highly antigenic. And if you get infected with strep pyogenes and you are infected long enough, you start to make antibodies against protein M. And antibodies 2 protein M cross react with heart valve tissue. So if we look on the top, and if this, for example, is a bicuspid valve, looking at it from the top, these antibodies will bind when they bind, they will activate complement. These will cause damage to the valves. That damage to the valves will thicken them and it will cause them to be rough. This is why if someone has strep throat, you treat right away so that it doesn't cause rheumatic heart. Now, typically in a young person, rheumatic heart will cause endocarditis type symptoms and then it'll pass. But those heart valves are roughened. Should they get microbes introduced into their system, those microbes have a much higher tendency to cause infective endocarditis. All right, so this gets roughened. And after it gets roughened, that means microbes that get introduced into your bloodstream now have all kinds of nooks and crannies to hide in. If they hide in that, they can damage the valve, expose collagen, cause platelets to adhere, and form vegetations. That damages the heart valve further. The valve now will get thicker and shorter and thicker and shorter and thicker and shorter. As you repeatedly damage it, roughen it, recolonize it, damage it, thicken it, roughen it, recolonize it. And also, you are essentially making trenches in which these bacteria can colonize. It would be very difficult to get rid of that infection. So that's why a roughened heart valve predisposes someone to infective endocarditis. Now, can people with native heart valves that aren't roughened get endocarditis? Yes, they can. So the valves most commonly affected are on the left side. So that would be the mitral valve. And also the aortic valve. So bacterial colonies and clots and fibrin will form. You'll get vegetations. This infection can be acute, where you get lots of damage quickly and you get pretty robust symptoms, fulminant symptoms, or it can be subacute, depending on the organisms that cause it. Let's talk about some of those organisms. All right, now dental work will usually introduce organisms from your oral cavity. And the most common denizens that will cause infective endocarditis are viridans, streptococci. This is a group of streptococci, but the organism most likely to cause infective endocarditis is Streptococcus sanguinis. That's the most common cause of so-called native valve infectious endocarditis. Viridans streptococci can adhere to the heart valve quite effectively because they make a dextran capsule. That's also the way they stick to your teeth so effectively. Now, if someone has had, say, head trauma, repeated surgeries, or something like that, then the most common cause of infective endocarditis is Staphylococcus aureus. And this will cause an acute infective endocarditis. In this case, if the bacteria are introduced via wounds, surgeries, or by intravenous drug use, then they will most often tend to affect the tricuspid valve. All right, with me so far? Yeah? Okay, good. Now, what if someone has prosthetic valves? Now, one of your biggest offenders is going to be Staphylococcus epidermidis. The Staph epidermidis loves to form biofilms on prosthetic material. And so if you say you do ICU nursing or something like that, patient all of a sudden spikes a fever, starts to get new arrhythmias that they didn't have, and say they have a PICC line, central line, maybe Foley catheter or something like that. Oh, well, they had a UTI, but we cleared that up. Staph epidermidis should be one of your first thoughts. And if you get a question like that on the NCLEX, where someone looks like they have the signs of infective endocarditis and they have some sort of implant, Staph epi should be your first go-to in your thinking. Very good. Let's take a look at some other causes of infectious endocarditis. Colon cancer can cause colorectal bleeding. There are certain bacteria that tend to be associated with colorectal carcinomas. They can colonize the bloodstream and cause infective endocarditis. So the main offender here is Streptococcus gallolyticus. Used to be called Strep bovis. Now they changed the name to something not nearly as easily remembered. Streptococcus gallolyticus. And then there are some endocarditis that you get from organisms you get from animals. One of those is Q fever. Q fever is caused by Coxiella burnetii. This organism is an obligate intracellular parasite. It cannot be cultured. And this can develop months after the initial infection. So if you've got an infective endocarditis, that's a real head scratcher. Can't culture it on the blood cultures. There was an earlier Q fever infection. Your warning bells essentially should go off. Now, Q fever may not cause any symptoms initially. Oh yeah, I had this, kind of slight pneumonia. I felt really tired, went away. Will usually be an association with animals. Farm animals, usually things like that. Now, one other infection is usually associated with cats, and that is Bartonella. There's usually several different species of Bartonella that may cause this. But the one that's usually going to cause endocarditis is this one. Henselei. So this you get from cats. There's an association with cats with Bartonella. All right. A few more here. Oral bacteria. There's a group of oral bacteria that can cause a minority of infectious endocarditis. This group is collectively known as the HASSIC group. These group, they're oral bacteria. They're all gram-negative. So H stands for Haemophilus, A stands for Aggregatibacter, C stands for Cardiobacteria, E stands for Eikenella, and K stands for Kingella. That's why it's called HASSIC. These were thought to cause a lot of endocarditis. Now it turns out they cause a minority of it. So the HASSIC group, you treat them all the same. The treatment you use for them is the same pretty much. They're gram-negative, but they cause a minority of the infective endocarditises. Okay, and then rarely, your IV drug users can get Pseudomonas. They get Pseudomonas ruginosa, infections of the heart valves, or the yeast Candida. Usually albicans, but other species are starting to show up as well. And again, because this is IV drug, these will tend to infect the tricuspid valve. So those are the denizens that cause infective endocarditis. Any questions about any or all of those? Yes, Sophia?
Drug use, I assume you mean like illegal drugs.
Yes.
Like hospitalized?
No. No. If it isn't, that nurse should be fired. No. The protocols for putting in an IV, the cleansing and things like that that go on, it's not very common. At least in this country. In other countries, there are infection rates that are higher. In this country, infections from hospital IVs are quite low. Quite low. And when you get into all that, you'll see why. And I mean, your mother's a nurse, you've probably seen her put in IVs. The rigmarole you go through to make sure that the area is clean is daunting. But that's why infection rates are so low. And you get these stories about infection rates in hospitals where you could follow a nurse around and you can tell which patient's going to get infected. Those nurses don't last very long. So, signs and symptoms of infective endocarditis. Fever is very common. There's also usually a new heart murmur. That new heart murmur results from turbulent blood flow passing the damaged heart valve. Septic emboli, particularly those from the left side of the heart, can detach and they can lodge in arterial circulation elsewhere. So they can cause ischemic strokes. Right-sided ones, the tricuspid valve, they will tend to dislodge and cause pulmonary embolisms. Paradoxically, if you have someone with atrial septal defects, you can have a right-sided embolism that actually detaches and flows through to the left side. That would be in someone who has an atrial septic defect. Septic emboli can also get stuck under the fingernails. Well, they get stuck in vessels that are found under the fingernails. So you get these things under the fingernails called splinter hemorrhages. Splinter hemorrhages. Splinter hemorrhages, you can also see these flat erythematous lesions on the palms of the hands or the soles of the feet. Those are called Janeway lesions. Janeway lesions. Boy, these walls are thin. So again, Janeway lesions that tend to be on the palms or soles of the feet. They're flat, painless, erythematous lesions. You can also get antigen antibody complexes that will deposit in different parts of the bodies. In the fingers and toes, these complexes can lead to painful red raised lesions. So whereas Janeway lesions are flat and not painful, these other lesions that are antibody antigen complexes that lodge in the tissue, those are called Osler's nodes. Osler's nodes. And if they reach the eye, in the retina of the eye, on an eye exam, you will see what are called Roth spots. Roth spots. And if those deposits reach the kidney, they will cause glomerulonephritis. And that will present usually with oliguria. Oliguria means low urine output. And then high serum levels of So blood urea nitrogen will be high. And so will creatinine. Which that's what you expect in a case of a kidney that's not working. Well, kidneys that aren't working. You have two of them. If you suspect someone has infective endocarditis, you must draw blood cultures. So a blood culture is a bottle. It has a blood medium in it. With the top that you inject, you do a draw from the patient. You do a draw from the patient. That's supposed to be an arm. You do a draw. And then that goes in here. Never made any claim to being an artist. And then this you put in the incubator. You're looking for growth. Should, in a healthy person, should that grow anything? Yep. So if you get cells growing in a blood culture, that's a pretty safe bet. You have blood in the, you have microbes in the blood. And it also means that those microbes could be infecting the heart. There is a set of criteria you must satisfy for infective endocarditis. They're called the Dukes criteria. And the Duke criteria, I actually had a nice handout for you and I left it back in my office, which means I'll hand it out to you in lab. But the Duke criteria usually involve major and minor criteria. So the presence of Janeway lesions, Osler's nodules or splinter hemorrhages, those are minor criteria. The isolation of the organism in a blood culture, you have to take 3 blood cultures over a period of 2 days. 2 of those have to be positive. So you have to have one major, either 2 major criteria or one major, 3 minor, something like that. And if you satisfy the Duke criteria, that says you have infective endocarditis. To visualize the vegetations on the heart, you're going to use transthoracic echocardiograms, echocardiography. And you can see the vegetations, and sometimes you can see the clots forming. You can see them dancing on top of the vessel. It's the valve. It's pretty remarkable. Okay, treatment. Treatment. First line will be vancomycin. So empirically, you're always going to use vancomycin, and then what you add to it will depend on what you think might be causing the endocarditis. If you have, say, for example, someone whom you think is infected, say, with Staphylococcus aureus or something like that, or say maybe Streptococcus, then you'll add something like ceftriaxone. What, however, is the case if you have an IV drug user? You have an IV drug user, then you use vancomycin And in this case, you'll add cefepime. If your patient has a allergy to beta-lactams or cephalosporins, your alternative will be ciprofloxacin. Now, what do you do if it's one of these MRSA strains that's resistant to vancomycin? Then you're going to use either daptomycin or linezolid. Vancomycin ceftriaxone is also a good choice if you have artificial heart valves. So that for these, you need to treat for at least 6 weeks. All right. That's as much as I dare say about infective endocarditis. You guys will definitely see infective endocarditis in your careers. So. All right. Okay, septicemia. So with sepsis, you have a compromise of some sort of barrier. The microbes cross the barrier, they colonize the bloodstream. You get this massive inflammation. That massive inflammation can cause this condition called septic shock, where the patient's blood pressure now starts to tank. They're going to have end organ damage unless you do something about that. What do you do usually to get the blood pressure up? Fluids, very good. That's usually thing one. What's the other thing you use? Pressors. These groups of drugs called pressors that cause vasoconstriction. So epinephrine, norepinephrine, vasopressin, these types of drugs, they'll raise the blood pressure. Sepsis will cause a condition sometimes called disseminated intravascular coagulation. This is most commonly seen in cases of septicemia where you have gram-negative bacteria that are the culprit. The lipopolysaccharide of the bacteria causes massive cytokine release, and you get all this clotting that occurs just inside the blood vessels. That essentially wipes out all your clotting factors. And then that clotted material gets degraded very slowly. And so you don't have any fibrin left. This can cause bleeding, massive bleeds all over the body. So this is not something to take lightly. So this can cause multiple organ damage. There are several different organisms that are quite good at causing sepsis, but it's usually due, in many cases, it's hospital acquired in many cases. In other cases, it's due to local infections, where the local infection then seeds the blood. Local infections that are probably the biggest risk are cellulitis. In that case, the staphylococcus. That is your biggest culprit. So fevers, very prominent feature of sepsis. So is tachycardia and tachypnea. Hypotension is also quite common. The patient will have very cool skin. Cyanosis. You might see modeling of the skin because of increased capillary refill. The patient may have agitation or lethargy, even stupor. You'll have reduced bowel sounds. So to determine the severity of septicemia, there's this thing called the SOFA score. Let's go over the SOFA score. So this is the quick, it's called SOFA because that stands for sequential organ failure assessment. Hence the name SOFA score. And this will be on a 0 to 3 scale. So if your respiratory rate is greater than 22 breaths per minute, that gives you a score of 1. If your mental status changes, so you're going to use the Glasgow Coma score. If that if it's below 15, that's another 1. And if your systolic blood pressure if that gets equal to or below 100, that's another 1. So a score equal to or above 2 increases your mortality risk. SOFA score is SOFA score is a very quick and easy way essentially to determine what kind of peril your patient is in. So you're going to treat with really broad spectrum antibiotics IV, and you're going to give fluids and vasopressors. I think that's the best we can do with that one. The other infection we could talk about is typhus. I don't know if you guys will ever see a case of typhus. Although at UC Irvine, there was a case of murine typhus that a social work student got because she went out and lived with the homeless for an assignment, and she came back with a case of murine typhus. Murine typhus, fortunately, is not very severe. I sure scared the heck out of her. All right, read the chapter because we've got to go on. We just don't have time. There's more we can say. So I will podcast gastrointestinal infections. Friday, we'll do respiratory infections. And then Monday, urinary tract, STIs. And that'll be it.
When can we come in for our labs to read? No, we don't.
We have lab this
We
week.
do?
Yeah,
Okay.
we have lab this week. It's over a week of content.
Well, I thought you said that since it was like the last.
Right, we have lab this week and then you'll need to come in off hours from the labs we do this week. Yeah, you got your weeks mixed up there, Gracie. And your lab books are in the office, pick up, they're rated.